and welcome to this meeting of the Healthier Communities and Older People Overview and Scrutiny Panel. Item 1 is apologies for absence. Are there any apologies?
Chair, we have apologies from Diane Griffin, co-op member, and
Well, thank you, Joan, for attending. I understand that Mary has a chest infection and is pretty poorly, so we send our best wishes to her, I'm sure. Item 2 is declarations of pecuniary interest. Are there any declarations? Good. Item 3 is the minutes of the previous meeting. Are they approved? Nigel, you've got an issue. Could you put your mic on, please? Nigel, could you put your mic on?
Sorry about that, Chair. If you look on page 3, term 6, it's mentioned that the cabinet member would come back at the next meeting, and in the today's agenda, it's not on there.
Nigel, you're quite right. That's what we agreed, and it's an oversight on my part, for which I apologise. I've spoken to the cabinet member and asked her if she could come back for the next meeting. She's kindly agreed to do that. So if you forgive me, that's entirely my fault.
Okay, thank you.
Are there any other issues in relation to the minutes? Okay, so the minutes are approved. Item 4 is the budget and business plan, and Caroline Holland has kindly come along to brief us, and she will introduce this item very briefly. Caroline.
Thank you, Chair. So this is the normal first round report that I bring you with the first update of our MTFS against the business plan that we brought to you in Council in March earlier this year. So as you can see, there's some significant issues that we've looked at and revised our assumptions on, not only pay, because the unions have rejected the current pay offer of 1.75%. So we're waiting to see if there's going to be any potential ballots for strike action. Inflation is an issue for us at the moment, and probably for yourselves and your own local household affairs, with just energy, the fuel issues, as well as the rates of inflation. So we have changed our assumptions around inflation, particularly for 22-23, because we're aware of some of the impacts that some of the contracts, particularly for some social care providers, if there's an inflation-linked annual uplift, then that's going to cause some issues. So we have allowed for some additional inflation there as well. Clearly, if you've been looking at the monitoring reports, you'll have seen that we have been struggling with delivery of certain savings, partly still due to the impact of COVID. So we have decided to, for 1 year only, to write out unachieved savings as at month 4 for 2021 and 21-22. We have also reversed out the decision that was taken at the October Cabinet of the emissions-based charging. So you'll see in the table on page 31, excuse me, that there's an adjustment of 3.6 million for savings no longer achievable. COVID is still having an impact on us this year, and we expect certainly in environment and regeneration from income levels that there will be an ongoing assumption. So we are still working through what that might mean for us. Clearly, we've tried to do a worst case scenario of some of the items. So we have built in the employer's increase in national insurance. Even the spend in the government's budget that was announced last Wednesday, we were told that we would get funded for that, but it appears it's going to be on a formula basis. So that will add some challenges because we're not sure if we're going to benefit or lose out as a result of that formula. The budget also made some announcements regarding the levels of council tax. So the referendum limit is likely to stay at 2%, but we will be able to charge, if we wish to do so, an adult social care precept of 1%. So whilst that doesn't help my bottom line and gap, it will certainly help you and your service areas, because that'll be additional money for you to spend on. There may be some areas where if you're in a surplus position, I know John will defend this strongly, to see if we can actually sort of some of the inflation that we've set aside corporately, if we don't need to give it to you because you've now got that adult social care precept, we'll see what that does mean for you as well. We're unlikely to get the provisional settlement until just before Christmas, so around about the 15th of December. So that certainly doesn't help some of the planning that we've got to do. So we set targets for the departments, and we'll be coming back to Cabinet in December, and therefore scrutiny in early January with some savings proposals. We have tried to minimise the level of savings required in next year because of the difficulty of achieving some of the savings already in these few years, but because of the impact of COVID and struggling to do that with such short notice with the level of savings, we've utilised and earmarked some earmarked reserves to try and minimise that gap as much as possible. So you can see that we've got nearly 9.4 million of one-off monies that we're using in 22-23, but then as that gets built back in 23-24, that's why there's a significant increase in that year. We are also currently in the middle of having safety valve meetings with the DfE regarding our DSG deficits. And if we choose to accept any deal being proposed by them, unfortunately, we won't know the details of that till January. So again, certain things are sort of, it's taken quite a while to line up. So it could still be quite a hectic January, February, and probably March issue for us as well. So you will see that the gap next year has reduced from what we said in March, just over to 1.1 million, but significantly increased in 23-24 to 17 million. So some challenges ahead for us. And the government has said that there's no separate COVID monies to come. So we'll have to work our way through what that settlement does mean for us. But there's additional monies for the social care reform within that, but we're not sure on the basis of which they've calculated the monies that have been set aside, because I know certainly with John, the work that he started, it's quite complicated to get your head around what the reforms do actually mean on an individual basis and on an authority basis. But that work is starting, and we'll keep you informed as we go through. Thank you, Chair.
Thank you, Caroline. Are there any questions to the Director?
Caroline, thank you for your very good presentation. I noticed that adult social care at the moment is in a favourable variance, and I just wanted to ask whether this was due to extra monies coming in, or because the pandemic has affected the way in which the money should have been spent and wasn't. Thank you.
So clearly there is still some additional monies coming in to adult social care. But I think John would say this is predominantly due to the CCGs paying for the discharges during the course of this year. So we need to see how that plays out during the course of next year. There were currently less people receiving services, but those numbers are beginning to increase. And we're just waiting then for the winter pressure spike to see what happens there. We have actually received some winter pressure funding, so we're just again working through, but that will be dependent on being able to recruit staff to help us with what we need to do over the winter, because winter does appear to be coming quite early and not just in this room.
Any other questions? Okay, so we note the report that we've had on the budget and business plan 21-22, and we now move on to, actually I'm going to change the agenda round because Mike Proctor is going to talk about the post-COVID 19 syndrome. Is Mike's joining us virtually? Yes. Okay, is he there? I understand, Mike, you need to leave at 8 o'clock because you've got another meeting to go to. Is that correct?
Yes, that's correct, Chair. And apologies, I'm still trying to get my camera to go the right way around. You've got a great view of my bookcase at the moment. Hold on.
You could always sit the other side of the table.
It might get to that.
That might be quicker.
It would be at the current rate of progress. So while I struggle with that, Chair, I'll make a start anyway. I won't go right through the presentation because hopefully you've had a chance to look at that. But the slides basically take you, first of all, just a quick description for those who don't know what post-COVID is. It's the clinical definitions are there on the slides, which is basically that this is for people who have had COVID symptoms which are persisting after 12 weeks and are therefore an ongoing problem for them. There is a brief description of some of the principal symptoms that people will suffer from. The main ones being fatigue, shortness of breath, and a general feeling of tiredness. So some of the symptoms are slightly imprecise, and that's one of the reasons why the levels of prevalence for this particular condition are not necessarily particularly easy to pin down. There's some information there on what the risk factors are, which particular groups seem to be most prone to this, and the sort of impact that it can have, which is basically that post-COVID tends to make people unable to function properly. They're not necessarily especially ill, but just fairly ordinary daily activities, and certainly things like exercise or work are a great deal harder. There is a slide number 8 in this pack about the estimates of the current prevalence, and some of the ONS estimates suggest that for Merton there could be up to 3,000 people suffering these symptoms in one way or another. You won't be surprised to hear that we don't actually have 3,000 people contacting the services. So I think a lot of this is difficult to pin down because the symptoms are quite general. There are two ways you can really look at prevalence. One is the number of people who do present to services. The other is to take levels of infection in the community and then sort of make an estimate on what you think they should be, given that the numbers of people contacting services is probably an underestimate. But it is quite difficult. The service that we have running, and this covers Wandsworth as well as Merton, it's a joint service with the neighbouring borough, but typically we'll get about 25 new referrals a week. There's a description there of some of the structures of the programme and how it's set up. I won't go into that, but we do have a local group covering Merton and Wandsworth, organising the service and monitoring it. That group meets on a fortnightly basis. And there is also an overarching Southwest London programme to coordinate the introduction and development of these services. Moving on to the actual treatment and the services that are available, slide 11 of the pack on this topic shows that 4 tiers. And the one that I'm going to spend just a minute or so on is the third as you go up from the bottom then, which is the borough-based post-COVID assessment service. Below that, there is obviously the GPs and support in the community. And then at the very top of the pyramid, there is the very specialist services for those who are really ill, and those are obviously hospital-based services. But the majority of people who are receiving treatment for post-COVID would be in that third group, the borough-based post-COVID assessment service. So there are a number of slides here. Again, I won't go through them in the interest of time. Hopefully members have had a chance to look at this. There's some information on the demographics. So we're seeing rather more females than male accessing the service. There is a breakdown in terms of ethnicity, which confirms our suspicion that it's sort of non-white groups who perhaps are most affected by COVID sometimes, if you look at that as proportions of those groups within the borough, generally, just the demographics rather than those with the disease. There is some information on the presenting symptoms. So again, a general feeling of tiredness and also breathlessness, which of course can be very alarming, are far and away the most important or prevalent physical conditions. But as well as the physical conditions, there are the psychological and mental health issues and psychological symptoms, and especially anxiety is a significant aspect of post-COVID. So there's a rather hard to read slide there on the pathway, but what that basically shows is that when patients come into the assessment service, they can either be treated there and then. If they're particularly serious, they would obviously be referred up to specialist hospital services, or they'll be given some sort of more primary care-based intervention with some social prescribing. And the next slide gives us some examples of some of the therapy interventions that we can use for those patients who do have symptoms, but who don't necessarily need specialist hospital treatment to help them manage some of the problems that they're having. There's then some more information on the expected recovery times, and this is something which should go away really within a few weeks. There might be some tiredness lingering on for a few months. Patients who are still suffering this from after 6 months is probably because they've had some very serious hospital treatment when they were acutely ill with COVID in the first place. So, on a ventilator or something like that, in which case, obviously, it will be a longer recovery time. But overall, we would expect most patients to be discharged from the service within a few weeks, if not indeed a couple of months. So that's a quick overview, Chair, and I'm happy to take any questions, and I will try and become visible whilst we do that.
Thank you, Mike. Over to the panel. Are there any questions? Nigel.
Thank you. Thank you. I am, I'm sorry to, hear about the, long term, illness and etc. I have a question, because I know someone who suffered from ME, which is another type of illness. And if you look on page 15 of your presentation, it says a link between the long-term COVID effects and ME, and other lessons can be learned from it. Thank you.
Mike, did you get that?
I'm afraid the connection wasn't so great. I didn't get all of that. I'm afraid, Chair.
I think the question was that is there a similarity on your slide 15 with ME, and are there any lessons that could be transferable from that condition?
Right. Thank you. Thank you, Chair. I think the short answer is yes, there are similarities, and certainly some of the therapy support that we use to address these issues. So the techniques that are used by the therapists, specifically the physiotherapists, but also the occupational therapists, have drawn to some degree on the lessons of treating ME.
Any other questions? Linda?
Mine's not so much a question, but I've been reading this book about breath and breathing. And one of the things it talks about is mouth breathing being not helpful because the air isn't filtered. Do you think that in the, I don't know whether you would know the answer to this, but in the section where they're, in terms of support, they're talking about breathing patterns. Do you think they're discussing that particular issue? Because I found that really quite fascinating. And it's also in the book that I'm reading, it's quite well researched, and it's talking about how some of the physical illnesses that people have that are affected by their breathing and how they can be actually changed by breathing back through your nose again. I know it all sounds very weird, but it's a fascinating book. And given that this is linked to lungs, a lot of it is linked to lungs. Is there any connection with that? Does it ring a bell, or would it be worth doing some research on?
It may possibly. I'm afraid that's a bit too clinical for me. I would have to to one of my clinical colleagues to see if that's something that's been looked into. So I'm afraid I can't help on that one. It certainly sounds interesting and a good possibility.
Eleanor.
Yeah, thanks very much for the presentation, and obviously, you know, an issue which is affecting a lot of residents. My question was about on the pyramid that you've got of the different kinds of treatment for COVID and then long COVID. How confident are we that it is a smooth transfer? For example, if you are discharged from hospital into community care, how smooth is that process? I certainly heard reports from people in the borough earlier on in the pandemic that wasn't a smooth process, and they found that quite difficult with the discharge of relatives who, for example, were still on oxygen. You know, oxygen canisters were not being delivered. They weren't sure how to care for their relatives at home. And I think everyone can appreciate it was very difficult during that January peak, but how confident are we that that's become a smoother process and people are getting the support they need as they are discharged and they move into the different forms of care?
I think we are fairly confident now. I think you're right. There were some teething issues as these new services emerged and we established them and how they interfaced with existing services. But the steering groups and the working groups that operate on this, both at the South West London level and then more locally for Merton and Wandsworth, are multi-agency groups. And we have ironed out, I think, most of the issues where patients have had to move both ways up and down the scale of when they need to be escalated from a lower level of intervention to a higher level, but then coming back down the other way once they're ready to step down. But then if their situation deteriorates again, to then step them back up without having to go through a re-referral process through their GP. So I wouldn't say everything's perfect because that's tempting fate, but I think we have tackled those issues, and it seems, as far as I'm aware, to be now working fairly well. It will obviously vary from case to case, because one of the issues with post-COVID is that it is a collection of disparate and sometimes hard to define conditions. Most people, if you look at the percentages on the slides, you'll see it doesn't add up to 100 because most people have far more than one of those particular ailments. And so it can be difficult in terms of seeing how well people are doing. But by and large, I think we've made a lot of progress on that.
Thank you. Any other questions? I've got one, Mike. How are people who have been discharged aware of these services? And is that, given the demographics of those that are more likely to suffer from this, what efforts are being made to reach those groups?
So are we talking, Chair, of people who've actually had COVID and been in treatment? Because I think that for them, we're fairly confident that they would be directed straight into post-COVID services and would be aware of them, even if they didn't need them. I think the unreached group would be more people who have suffered COVID symptoms at home, haven't been ill enough to necessarily need hospitalization or possibly even any medical help at all, if they've been one of those for whom COVID was not particularly serious during its original acute phase, but then is lingering on. And that's the bits that we don't have. So one of the big initiatives we've had most recently is on case finding, as we call it. So it's doing exactly that. Those people who haven't been in touch with services because they've managed COVID themselves, but who are nevertheless suffering from some sort of post-COVID. And it's to make people aware that, say, a feeling of tiredness or breathlessness that they may think is just something that they have to put up with, or perhaps something that they don't need to do anything about, how we can actively work with them. And you're quite right, it's some of the particular groups in the community who we might be most concerned about would be harder to reach. So we've been working with the Director of Public Health's colleagues in terms of identifying what are the existing community groups that we are using for different aspects of the community, and how we might use them to reach out to make people aware of the likely symptoms of post-COVID, but also the services that are available and what they should do. So that sort of proactive going to actually try and find people rather than just hoping that they come and present to their GP or some other form of health service is something that we're now making quite a lot of good progress on. And thank you for the prompt to thank the Director of Public Health for the work that her team have done in helping us with that.
Thank you. Are there any other questions? Okay, well, thank you very much for that, Mike. Now, as I understand it, you've got to leave in 20 minutes. So can we move straight on to primary care access? And if you could lead us through that, please.
Okay, so what we've got in the slides that you have in your packs is just a summary of the range of offers that there are from primary care in terms of accessing either through your normal local practice during what they call core hours, which is from 8 in the morning to 6:30 in the evening. Then there are extended hours. This varies from practice to practice. The core hours are obviously the same for all practices. And then there are the access hubs, and there are only 6 of those across the borough, and the location of those is set out in the pack. And the punchline basically is that everyone in the borough should be able to access primary care from 8 in the morning till 8 in the evening, wherever they are. Now, that doesn't mean, of course, that your local practice will be open for all of that time. It's quite unlikely that, for example, if it's late on a Sunday evening, it would only be one of the access hubs. And there are probably only 2 of those which would be open, 2 of those 6 which would be open absolutely all of the time, which is the Wideway Medical Centre toward the east of the borough and the Nelson toward the west. But it does mean that between them, the ordinary access, the extended access, and the access hubs mean that there is comprehensive primary care coverage 8 till 8, 7 days a week. Then, of course, there are also the out-of-hours services for those who need them as well. So that's basically what those first few slides summarize, those various different offers. There's also information in the pack about the patient survey and the levels of satisfaction and how easy people find it to reach their GPs. You'll see that the figures for Merton are a little bit below the average for South West London, and so we're continuing to work on that, although there is the important caveat that the actual sample size from the patient survey is actually very small. Most people choose not to respond, although everybody's invited to do so. So I suppose you could say that therefore the majority of people are probably reasonably happy, because when people are unhappy, they tend to make their feelings known. But anyway, we will continue to work on that. And then the final slide is basically sets out some of the issues and challenges that primary care is facing about the increasing demand, the fact that there has been an additional burden on primary care through the pandemic with the vaccination program, which, although it's been a big success in itself, has of course diverted quite a lot of resources. There's also the ongoing need to try and protect the acute hospital sector for the most seriously ill people, and that has become a big issue again just in recent weeks, where most of our local hospitals are really very, very busy indeed. And that means that therefore we do try to contain people with lower level illness within the community, but then that does produce a greater burden on general practice. And then there are the ongoing developments and reforms within the NHS, such as the development of primary care networks, and now, of course, we have the integrated care system. So a lot of pressure on primary care. You'll be aware that the government has responded to what it perceives to be a wish amongst many people to go back to the face-to-face appointments, which used to be the norm before the pandemic. And then during the pandemic, for reasons of infection control, most consultations took place remotely. And so there's now a push to get more availability of face-to-face appointments if that is what a patient prefers. A lot of people are very happy with the remote consultations, but we still need to try and accommodate those who prefer the face-to-face. And so there is additional funding being made to try and expand capacity, and we're currently working with practices on how we do that. That funding, which is tied to winter and making sure that people can access GP during the winter period, is actually quite significant, and is well over £100,000 per month just for Merton. So it is a significant investment, and patients should start to see the benefit of that very soon. But I'll just stop there, Chair, and see if there are any queries or questions on any of that or related matters.
Thank you, Helena.
Yeah, thank you for the presentation. My question is about making GP appointments. And I'm talking about the slides on what is page 8 of the PowerPoint. It also says page 80, the GP patient survey. First, a question really about the grid, the table at the bottom. It says, how would you describe your experience of making an appointment? And it says average.good, 67% in Merton, turning to 71% in 2021. Now, I don't know if that means 71% of people thought their experience was average or good, or on average good. I don't know what that means, so perhaps you can shed some light on that. But I think it points to a broader issue, and I was quite concerned actually to hear that you thought making GP appointments isn't an issue, because I think this is something we hear a lot from people, both during the pandemic but also before. Most GP surgeries now, to make an appointment, you have to phone up during working hours, and you have to be prepared to sit on hold for a very long time, which is very difficult for people who are doing shift work. It's very difficult for people who are busy during the day. Too many GP surgeries only have that one channel to make appointments in office hours, which automatically limits people's ability to make appointments with their GPs. And then even when they can get through on the phone, it's extremely hard for them to get an appointment within a reasonable timescale. Just to give an illustration of this, somebody who works in a care home was telling me that they phone up, 8 o'clock on the dot, and they're 30th in the queue, and they have to go to their shift in the care home. So that's that. And they do need to see a GP because they are encountering patients who have infections and they need to get things checked. So I just think this is quite a big issue, accessing GP appointments, and I would like to see more data on this. And also, how are we making sure that those GP appointments that we do have are actually accessible to everyone, whatever their working patterns and whatever their level of technological access? Thank you.
So just to respond, Chair, I certainly recognise all of those issues, and I realise that for some people it isn't easy to get an appointment, especially if they have restrictions on when they can either access the GP or when they're able to ring up if indeed they're put on hold for a long time. This is what I think a lot of the funding that I've talked about and the access initiatives which will be taking place across the winter months are trying to address. So we do recognise that there is some way to go to get to the level where we would be happy to this, but some of it is just about constraints on the workforce and the numbers of GPs that we have. But within that, as I say, there is now additional funding for us to try and improve access and improve capacity.
No.
Yeah, I think mine's on the same topic, really. I think my GP is pretty good. I don't really have a problem trying to get an appointment. And I think the promotion of online appointments is very important for those people who can access it. But I know we don't have a sort of an Ofsted of GPs, but is there any kind of attempt to spread good practice from those that seem to be able to perform extremely well to those practices that don't? Is anything going on in that regard?
Yes, absolutely. The new initiative around access and the funding that I previously described does exactly that. It tries to identify those practices which are doing well and those which are doing less well in terms of the accessibility of GPs and the how easy it is to access them. And that is will affect the deployment of the funding and how it is reviewed going forward. One of the issues we've got at the minute is some of issues around data quality, to be able to have reliable information on this. So, for example, if you're collecting information on, did you see your GP within a certain amount of time? If that's the question you ask and you haven't seen your GP, then you would obviously correctly say no. However, you may have seen the practice nurse, or you may have seen the specialist respiratory nurse or diabetes nurse, which for that particular patient was absolutely the right thing to do. So we need to sort those out, because otherwise we'll be sort of pressing in the wrong places. And the data collection, because we haven't monitored this in the same way before, the data collection routines aren't there. So we are working on it, but we just do need to improve the quality of the data, specifically about the questions that we're actually asking people about access.
Thanks. Just to follow on that question around the GP appointments. So the access hubs, I think you've said, are trying to solve that issue that people face. How do people make appointments at the access hubs? And how do we make that more accessible? It's in the name.
Yes. So when you it's usually through contacting your own GP. And if it's out of hours, and when your GP is not providing the core hours service, you will get a message instructing you how to access the alternatives, which might be some extended hours facility or indeed the access hubs. So they would give you the contact number, and then the patient would either have a telephone consultation, if that's what they preferred, or indeed make an appointment.
So sorry, Mike, does that
sorry.
mean that they have to phone the GP to make an appointment at the access hub, or they get an answer phone message on the GP out of hours to go to the access hub? I'm not following, sorry.
Sorry, so if they phoned their own practice and their practice was not at that time open, yes, they would get a voice message which would instruct them what to do. However, there are other routes into the access hub, so that if someone had rung, for example, 111, and the solution to their issue seemed to be primary care, but it was out of hours, then they could actually book the patient in directly. Similarly, from if someone presented to the A&E department at the hospital and it seemed more appropriate they were seen in primary care, they can actually book them in rather than say to them, well, no, you need to go away and see a GP. They could actually book them in, which might be to the access hub rather than their GP practice.
Can I ask a question? Well, a couple of questions, actually. Firstly, on the GP patient survey, I note that the field work was conducted between January and March 21. And I suspect that most people at that point were aware of the stresses and strains being faced by the NHS. It is my view, this is not science, but it's anecdotal, that if you were to ask people now, they would be saying they think it's about time that things started getting back to where they were, and that they're far from it. So my first question is, when can we see the data for the period that we're currently going through, or even from the summer? And my second question, very briefly, is when I look at the map that you've given us of the access hubs, it strikes me that the distribution is slightly skewed to the west of the borough. And I wonder if you would agree with me that having just the Pollard's Hill Wide Way Medical Centre, which is about as close to being out of the borough as you can be without actually being out of the borough, suggests that there is a need for another access hub in Mitcham, given the health inequalities that exist in the east of the borough.
So to answer your first question about the data, so that particular survey is the one that's done independently by Ipsos Mori. So that is an annual one. However, we will be, because of the new funding and the way it is going to be allocated and some of the conditions that apply to it, as I previously indicated, we will be getting more reliable access data very soon, because we need it for the way that scheme will operate. Because whenever new funding comes in, whether it's local government or the health service or anything else, I dare say, there's always conditions attached to it. So we have to be able to illustrate. So we will be that data collection is currently being developed. In terms of the location of the hubs, how they were originally identified, I'm not sure, but I do take your point about there being a bit of a gap between the sort of the Pollard's Hill and then when you go right across the rest of the eastern part of the borough. And I think that is probably something that we do need to look at.
Just following up on the first question, could you let us know approximately when that new information will be available, and undertake to come back and discuss this with the panel again? Because this is something that I think members are picking up from their discussions with the community that we represent, and this provides us with an opportunity to put questions to you and feedback to you, and we would welcome an early opportunity to do that. I see members nodding, so yeah, I think that's pretty unanimous. If you wouldn't mind making arrangements to come back soon, Mike, so that we can interrogate this particular issue again soon.
Yes, absolutely, Chair. We realise the importance that this has for people. Absolutely.
And you might at that point want to make an announcement about the new hub in the east of the borough that you've managed to identify and get up and running, and is showing remarkable results. Perhaps.
That would be lovely. That would be lovely, but you'll understand I may not make any firm promises on that one.
Janice, do you have a question?
Yes, just briefly, we talked about best practice being shared across the borough. If these surveys are being undertaken in other boroughs, surely if there's a sort of shining light, a centre of excellence in another borough, GP surgery, it's something that should be shared more widely so that we can learn from other boroughs what's happening there that is good, that we can also get our GPs to do to make the service better.
No, absolutely. That will absolutely happen. This scheme is being administered on a Southwest London basis. I mean, obviously it applies to the whole country, but the local deployment of it is on a Southwest London basis. So certainly any good practice areas in any of the other Southwest London boroughs that seemed applicable to other places, to help them to make access better. And then of course, yes, we will absolutely be doing that.
Okay, Thank you very much, Mike. I said that I would try and get you away on time. I believe there's 1 minute before you need to leave us. Thank you for answering our questions so succinctly, and we're grateful to you, and hope that you manage to get to your next meeting in time. But be careful when you're rushing about. Is it Wandsworth you're heading to?
It is, yes.
Right. Be careful. There's a lot of traffic out there tonight. But thank you for your contribution to our meeting this evening.
Thank you very much, Chair. Good evening.
Okay, so we now go back to the order of the published agenda, and the next item is the COVID-19 update, and Dagmar has been waiting. Oh, is it John that's going to present?
No, it's just I wanted to say one little thing. Mark Creelman was due to attend tonight on behalf of Health, and Mike stepped in at the last minute. So Mark had the executive locality director had a family issue that he's been on for a little while with. So Mike did step in at the last minute, and he didn't make that clear at the start. And I think, to his credit, he just stepped in at the last minute and fitted it in.
Well, clearly, are you still there, Mike?
I think he's gone.
Right. Well, in that case, I was aware that he had stepped in at the last minute, but he struck me as a very able substitute. And I hope that if my team have to make substitutes on Saturday, that they are as able as he has been this evening. Okay, so we're now going to move on to Dagmar. And this is for the very important COVID-19 update. Can I thank you for your patience, Dagmar, but you understood that Mike's situation was such that we needed to get through those two items first.
Yeah, so no problem. Thank you and good evening. So I'm Dagmar Zeuner, I'm the Director of Public Health. I think you probably will know me, but maybe there are any new faces. So I give you, as usual, the overview of what we call a situational awareness report. What is COVID doing in Merton? Stella, if you give me the next slide, that's the summary table. And the basic message is infections are hovering. They're sort of, you see the R value, which says how many people are infected by one positive. And if it's one, the pandemic isn't growing and it isn't shrinking. So we are desperate that it goes below one, because then it would shrink. And we really, really don't want it to go above one, because then it grows. And you can see it's around one at the moment. Now, what is really important to understand, this is from a high base. So if you remember, we're measuring our 7-day rate per 100,000. It's a bit of a convoluted measure, but that is the incidence, the number of new cases. And that is hovering around the official one, around 250. Sometimes yo-yoing up to 300, sometimes going down to 200. Now that's pretty big numbers if you calculate that as a daily basis. I wanted to draw your attention as well that this is not quite as up to date as you used to get the data. Because the pandemic has been a bit more steady and has been behaving around one, we are now updating every 2 weeks rather than every week. So I draw your attention that this was some data valid in the middle of October, but the situation hasn't gravely changed. We are now sitting all quite tight to observe in whether the half-term break has any impact, either good or bad. What is also important, we are looking in what cases we have, and it is 100% Delta. You will have heard Delta is the very transmissible variant that is now predominant. You might have heard that there were talks about another mutation of the Delta variant, sometimes called Delta Plus. We're working very closely with what is now called the UK Health Security Agency. So they are monitoring what's happening to this new mutation. And you will have probably heard that, I think it was last week, that UK Health Security Agency decided to call it a variant under investigation. So it's not yet a variant of concern, and it is monitored very tightly. So as soon as I will get any further data on that, I will share that in my situational awareness report. What we're then obviously looking is not just the numbers of infections, but the impact. And so we measure that through various indicators. One is outbreaks. And we have, particularly before half term, had numerous outbreaks in schools. And very importantly, the definition of an outbreak in school, which gets monitored through our London support, is really only picking up big outbreaks, big numbers. We are supporting schools even if they have smaller numbers of cases. So schools kept us on our toes, and I have to say, teachers, parents, they have actually been really brilliant and collaborative. The other bit, probably even more important, is what's happening to hospital admissions. And again, the picture there is steady. So people are still falling ill, but it is not going up. So if you move us on. I like that slide because you can see over time what has happened in Southwest London. So the different colours are the different boroughs. Merton is black. And you can see that the leader in Southwest London is sort of changing over time. So at the moment, it's actually Kingston and Sutton, in fact, and Richmond that are racing ahead. We're always trying to find particular explanations, but to be honest, it isn't completely clear, and there seems some randomness in the overall pattern. If you move us on. This is again showing you what I've just said around the hospital admissions. You can see the two humps where when we had our waves, where hospital admissions and admissions to ITU really went up dramatically. That is not the case despite high incidence rates. If you move us on. So really important for Merton is what is happening to inequalities. So we have always been measuring the infection rates in the west of the borough and the east of the borough. And you can see that the graphs, east is red and west is blue, are crossing over multiple times. At the moment, the west is slightly ahead. Really important is the right-hand upper quadrant because it shows you the age distribution. And you can see that the lead age group at the moment in terms of incidence are the youngsters, the 0 to 15, those who are not vaccinated yet, or where we're starting to vaccinate, because obviously you will have heard about the vaccination effort of the 12 to 15-year-olds. Apologies that sometimes the age bands aren't completely convenient. What is also important, though, you might have spotted on my summary slide at the beginning, is that we do now see some bleeding into the over 60s, and that is completely congruent with the science, how we understand that immunity starts to wane probably sort of 6 months after the second dose, and in those older people that we vaccinated first, this is now the time. So that makes it very, very important that the booster is really promoted and taken up. If you move us on. Testing hasn't gone out of fashion, although people are getting a bit tired. Plays its role, and again, just as a reminder, the PCR test is if you have symptoms, and the LFT, the lateral flow devices, are if you are in crowded areas, in a workplace, on public transport, and both tests are still widely available, free of charge in schools. In particular, you will have seen our renewed effort and campaign, kids coming back from half term, please to do the lateral flow test before they return to school. What's quite interesting, you can see in that week we had over 670 positive tests. The majority, almost 80%, were coming from PCR testing, but still over 20%, about just shy of 150, we picked up through asymptomatic testing. So if you think those would have wandered around happily spreading the virus, all of you, please continue to promote the use of the LFTs. They're easily available. They can be ordered through the internet, home delivered. They can be collected. And if people don't quite know how to do it, there are supervised sites as well. If you move us on. This is the slide which shows the worst impact. So this is the death graph. And the good news, the reassuring news is that the vaccine might not completely protect you against infection, but it so far looks really effective against what we call fatalities, so deaths. So we have the two big waves very visible in our death graph, and at the moment it is flat. If you move us on. So really, really important vaccination, and particularly vaccination, access to vaccination in all groups. You will have heard that uptake is varying by ethnic group. So we are very, very keen and put a lot of effort working with our community champions and our NHS to make the vaccine as accessible as possible for ethnic minority groups. And you see at the right-hand side, it's a very slow moving effort, but tiny improvements still to be seen. If you move us on. And here it's vaccination uptake by age group and geography. And again, the age bands, unfortunately, are not completely congruent the way we vaccinate now. It's there, the 10 to 14 and the 15 to 19 span, our 12 to 15-year-olds who we are vaccinating. But you can see the change in unvaccinated, the biggest negative numbers are in these young age groups, mirroring our efforts in schools and now also in our primary care centres and in the mass vaccination centres, where over half term this young cohort could just walk in to get their jab. On the right hand side again, you see in our important effort needs to continue to get access equity between East and West, particularly in the younger groups, 16 plus. You can see a very clear discrepancy. And so we're just at the moment doing a bit more deep dive into the data to really understand, and then working with our young people to work through what are some of the barriers that we can help to remove. If you move us on, I think that's me done. Okay, any questions?
Thank you very much, Dagmar. That's very clear. Helena.
Thanks, Dagmar. My question is on the deaths and also the vaccination rates. On the slide 7 on deaths, this was a question that came up last time as well, and I think there was an action to go away and look into this a bit more. Over 10% of the cumulative deaths that we've had in Merton throughout the whole pandemic have been people who've died at home, which I think struck us as quite a shocking figure. It could be that there's an explanation behind that. Perhaps also if we look into the rates of people who died in hospices, it may be underlying conditions. But I just wondered if we could perhaps for the next meeting find out a bit more about that. And was there a failure in the health system that meant those people died in their homes and not in a healthcare setting? And then on the vaccination rates, I think it is still very concerning, some of the gaps we have in the younger populations who have for some time been eligible to get their first and second doses and are still not catching up. My question is what are we doing to close those gaps? I know you mentioned the work of community champions, but are we, for example, using the NHS database to phone people who have been called in and give them a call and say, is there any questions you have? Can we give you a lift to the vaccination centre? That is what they've done in other boroughs, for example, Sandwell, very successfully. So the NHS data does exist to do that, and it is legal under GDPR. So I just wondered if that's something we could consider. And lastly, it would be good to get an overview of the booster rates as that picks up in these reports.
Yeah.
Thank you.
Will I come in? Really good, all really good points. So around the further analysis about our deaths, particularly deaths at home, they happened particularly in the first wave. I can go back and see whether we have got any further information and report back. We might have to use some application from some more specialized analysis that has been done elsewhere, and then see whether we can apply it to Merton. But I can also see whether we have got some direct death certification data. So give me a little bit of time. It is a very legitimate question. There are questions as well. If you really pick on it, is why had we got so many non-COVID deaths during these two spikes? They were actually higher than the COVID deaths. So our excess death from non-COVID causes exceeds the COVID one. So legitimate, still unexplained questions that I'm very happy to go back. On vaccination, any ideas on a postcard? We have, you will remember that we have had the sprint in the summer where we knocked at people's doors, where we phoned, and it is quite a fine balance because people have also said, can you leave me alone now? So this is in this country still a decision. And while we want to remove all barriers, we will not want to be perceived as hounding down people. So it is the ongoing dialogue and the openness. So we are inviting people and say it is legitimate. This has all been developed really fast. If you need more time, the evergreen offer is open. If you want to discuss it, with an expert, with a clinician, with a pharmacist, these offers are all ongoing. And I've just spoken this morning with one of my primary care colleagues, and she was actually saying it is slow and it is a hard slog, but we still vaccinate people with their first vaccine who have been eligible for months now. So really, really important that it's now it is a different phase of the pandemic as well. And it is not number one anymore on people's sort of agenda or radar. And so we have to adapt to that as well. But in the Health and Wellbeing Board, and Rebecca can report, we've got the community subgroup that specifically has chosen as a priority what we call vaccine equity. We've developed a vaccine equity plan that we are trying to deliver in partnership with the NHS and very, very importantly with the voluntary sector and the community. And councillors play, again, a really important role because they feed back how the community feels and what helps and what hinders.
Thank you. Janice.
Thank you. I have a friend whose child is at Rains Park High, and last week or the week before, it's half term, they were handed anti-vax leaflets outside the school gates. I know the head challenged the anti-vax campaigners. I'm slightly concerned because it might be more than one school being targeted. And what are we doing in Merton to counter that misinformation that is being handed out to 12 to 16-year-olds and perhaps influencing their decision not to have the vaccine?
Yeah, so again, Janice, really good question. Really very tricky. Some of the behaviour was very hard. So on some occasions we've called the police, and the police is obviously on standby and knows this. So when it was overstepping, what we've also learned is give as little airtime for that type of activity because it thrives on publicity. And then we have had a really good webinar, over 150 folks, for parents, for teachers, for youngsters, with our NHS colleagues, pharmacists, GP. They were all coming and supporting to answer questions from all angles, so that we give confidence to all of those, the parents, the teachers and the pupils themselves, in order to manage the anti-vax. There's also activity going on at London level. I can tell you we had letters being sent out to schools pretending these were from the NHS. This has been reported as fraud. We are getting, as directors of public health, all sorts of unpalatable stuff into our inbox. So it is being managed at London. Obviously at national level, there's awareness at London, and at sub-regional level with all our partners.
Joel?
Thank you, Chair. I understanding of term, in but it's not available in terms of data, but once it's available, are you able do and this by what's happening at school, the outbreak at many schools which have been heard, and then see what's in the whole term once it's available. And my second question, which is probably a long shot, and think you'll be working is the or then we are now in the stage having a booster jab, but what flu jab, because I am aware that if one person gets a flu and COVID at the same time. I was told if they said, is this something you're aware of? Thank you.
So, yeah, thank you very much. And I should have answered because there was a question around the booster. So if I start with your second question first, Nigel, at the moment, the data on the booster is only just coming in, but pretty good news is that the booster has been prioritized, particularly for care homes, because obviously those are our most vulnerable people. And the offer was meant to have gone through all the care homes by the 1st of November. We are the 2nd of November and we are nearly there. Again, as I told you, I had a meeting earlier with my NHS colleagues and they were very confident that within the next few days, all of the care home residents have had an offer. But I haven't got neat data yet. So the moment I have them, we're just redesigning how we're presenting and monitoring the uptake of the booster. We have to change our templates a bit. And then secondly, Nigel, you're absolutely right. Flu is also important for various reasons. One that you mentioned, that if you get flu and COVID together, you can be in a very poor place and we do not want it. But secondly, also our hospitals are already very busy, as you've heard Mike saying, and it's in the news every day. So if we're adding to COVID now significant flu cases, we're putting more strain on. So all good reasons to promote both. The flu vaccination has taken off well, particularly in community pharmacy, but I haven't got the data all brought together. Again, the moment I have it, I will add it into the report. So that's on booster and flu. The second one was around half term, and bear with me, I am not 100% sure whether I understood it completely, but half term, we are simply not quite sure what half-term impact on infection rates is. You will remember from last year that people were saying, oh, half-term could be a so-called circuit breaker for the infections, because when you have lots of infections in schools and the schools break up, infections might go down. What happened last year, though, is that after half-term it dipped and then it rocked up again. So what we are very much hoping this year is that maybe half-term gives us a bit of a reprieve, because during that 1 week there was less opportunity for school infections, and that we had a good offer of the 12 to 15 vaccination, that we're in a way starting to catch up, but we need to have a slightly longer breath, because the protection from the vaccination only kicks in after 2 weeks. So watch that space. And of course, Nigel, we are still having a tracker that looks at data. I look at data every day. I'm sharing it with my corporate management team, so with the chief executive of the council every other day. And then the situational awareness report is every other week. And the testing report is also every other week. So we're not taking our eye off, and I always feed it then back as a summary to overview and scrutiny. I hope I answered your question, Nigel.
Thank you, Dagmar. Are there any other questions? Okay, well, can we thank Dagmar for her report, and as always, thank her and her team for their efforts on behalf of our community, which are very much appreciated, both here and in the community. Thank you, Dagmar. So we now move on to item 8, which is community diagnostic hubs, plans for South West London. And we've got Dr. John Clark. Okay, he's not here yet. Okay. Okay, we'll do the work programme. Can we note the work programme? Right, that's noted. So we are now back to where we were. I'm not going to spin the work programme out. It is now 8:30. Okay, do you want to take a bit of a break and reconvene in 5 minutes? Helena, have you got a question that you wanted to put?
It's not a question, it's just a point for everyone to be aware of with the vaccinations. They've just changed the guidance and you can now have your flu jab and your booster on the same day. So just to get that out in the community, because a lot of people think they still have to leave a big gap between the two, which was the case a long time ago. It's now not the case. So people should just get both ASAP.
I had mine on the same day about a month ago. One in each arm. Felt fine the next day and felt more safe. So
May I just chip in, Chair? It's a really good point. One thing to consider is that where you need to leave a space is between your second COVID vaccination and the booster. So, for example, I had my flu jab, but I'm not yet due for the COVID booster, and I didn't want to hang in there and wait with the flu to have them together. So the messages need to be really nuanced. They can be given together, but don't wait for your flu jab if you're due and you're not due yet for the booster.
I went for my flu jab and was offered the pneumonia jab along with it. And then for the rest of the week, I had an absolutely diabolical arm that I couldn't lift. It was so heavy. So I was really glad I didn't have my booster along with that.
I hear you. I'm putting my coat on. It's starting to get cold in here, right? We're trying to keep the air circulating to protect us all, but we'll all have to get the pneumonia jab. The heating. No, it's the windows, they're open. I'm not sure that the Director of Public Health would encourage that, would you, Dagmar?
Sorry, it's a really tricky issue, and although we're joking, it's an honest trade-off, because ventilation is a very good means of protection, but making everybody feeling very cold is also not conducive to either a good meeting or the well-being. So we need to balance and find that sweet point.
Okay.
And we have sustainability. I might get that in. We don't want to heat out of the window either, to keep the.
Are our guests here? Okay. Tell me when they're here. Hello, is that Dr. Clark?
Hello, can you hear me?
Yes, we can now.
Apologies.
Welcome. We have finished all the other items on the agenda. So we'd like you to talk to item 8, which is the community diagnostic hubs, the plans for South West London. So over to you.
That's very kind. And forgive my tardiness. Your counterparts at Wandsworth were most keen to chat to me at length. So
They're always full of hot air over at Wandsworth Council. I don't expect you to respond to that.
So my name's John Clark. I'm a microbiology consultant at St Heliers, and I'm working as the kind of diagnostic lead for Southwest London to kind of oversee kind of diagnostic work. And as part of that now, you've come out of it, is this community diagnostic centre, formerly called Community Diagnostic Hub project. And there were some slides that were sent around, and I'll kind of assume that people have kind of looked at them, but I will kind of just go through some highlights. And this is part of a kind of a national strategy to improve diagnostic capacity. There's been a recognition that there is not enough diagnostics, be that imaging, so X-ray, CT, or heart scans, or spirometry, respiratory, lung function tests, etc. So ultimately, this is a good news story. They are looking to make funds available for areas to improve their diagnostics. And what they want to do is improve diagnostics in a way that increases the ability for diagnostics to be closer to the patients, closer to the public that use them, and be faster, so that people can be diagnosed and treated sooner. And so what we're looking at is how we dovetail having more diagnostics as a purely kind of raw number of scanners or whatever, alongside how we can do things differently and work differently to improve the patient pathway, the patient experience, to make it faster. And one of the things we're looking at is how we can utilize diagnostics in a way to condense some of these patient diagnostic pathways. So you have breathlessness, you go to see a doctor, you get the X-ray, you then get referred to the heart doctors in the hospital, who then see you, send you off for a scan. 6 weeks later, you have the scan. 6 weeks after that, you go back. And actually, can we do this so that you all get done in one day? And there's no reason why, with a bit of kind of work, that some of this isn't doable. And so what we're trying to do at the moment, and we're in the kind of early stages of a several-year plan, is to work out, well, how do we improve the diagnostics? Where can we use? What sites are available? What diagnostics do we need? And then how do we use those diagnostics with our hospital and our GP colleagues to improve the patient experience? And so far, we've bid for money for what's called the year one, which we were fortuitous enough to have a site over the Queen Mary site over in the kind of Richmond area, Wandsworth area, which was already been undergoing developments. And so out of necessity, we had to kind of utilize that site to put additional diagnostics in for MRI scanners, CTs, ultrasounds, echo and endoscopy. And we're now working through how we can utilize a site that meets the needs and the kind of focusing on improving diagnostics for those who have been, for whatever reason, those communities that have got health inequalities. And so we've identified, using our population health analytics across Southwest London, kind of areas of deprivation. There's some in Croydon, we have some around kind of St Helier and East Merton area, and then we've got some around the kind of Roehampton Queenstown estate. So we're looking at, for the kind of St Helier Merton area, utilising any existing NHS estate that we have, but also be mindful of how we can then reach into some of these more deprived, more in health inequality areas. And so we're looking at a model of a hub and spoke, where we have a kind of a larger diagnostic centre with some of the more kind of technically advanced, bigger kit that needs certain levels of expertise to use, as well as several spoke sites around where we can basically put in some diagnostics which have got a less kind of need for power or internet access or whatever. And so with the kind of St Helier estates that we have at the moment, one of the things we're looking at is utilising that site once the acute services have gone off. There's some kind of things that we need to do. We need to make sure that these are not part of acute hospitals. And so we're looking to sort of utilise it alongside some outpatient facilities, as well as we're now looking at several sites across kind of St Helier area to see whether any of those would be suitable as kind of spoke sites of varying sizes. We're also doing engagement work. So London has done a wide range in early engagement with the Imperial team. We did something in Southwest London, and we appreciate that even that was probably too high level and didn't really represent all of the populations. And so if you look at what the Southwest London work had done to date, which is in the slide set, you'll see kind of 70% white, so that doesn't necessarily reflect some of the populations. So we're now doing further engagement work, trying to reach into some of these populations that haven't necessarily stepped forward to fully understand their needs. And we're doing that alongside a similar kind of engagement piece of work with the hospital staff and the general practice staff to understand what their asks are as well. And so that's kind of where we're at in a nutshell, because I want to leave time for questions. I think it's very exciting. I think this is a real opportunity to not only improve the diagnostic offer to patients across Southwest London, but also an opportunity to do things differently to improve the overall kind of patient experience and improve diagnostics, to allow us to make diagnostics more rapidly to improve health outcomes. And I'll probably stop there and open up to your questions.
Thank you. Are there any questions? Well, John, you've either done such a good job presenting this that everyone thinks that there's nothing more to say, or it's possible that some of us are sort of suffering from hypothermia in an effort to keep the place well ventilated to protect us from catching things. So one more chance. Are there any questions? Okay, well, I think this is a development that is generally welcomed within the local community, and we'd like to thank you for updating us on your plans and your progress, and ask that you keep us informed. And also, I think very much the sentiment of this panel is to wish you well in developing this additional service, which we think will be very valuable. So thank you for coming. And I'm sorry they kept you so long at Wandsworth, and you'll see that we are much more business-like here in Merton, and we get through things at a very rapid pace. So thank you very much.
You're very welcome, and thank you.
Okay, well, in that case, it is, well, it's actually 20 to 10 by that clock, but I don't think it's as late as that. It's 20 to 9. So I suggest you all take the rest of the evening off and enjoy it. Thank you for coming, and thank you for